The definition of a protocol is an official procedure or a system of rules to be followed. PJ's protocol exemplifies just that. It educates us on the complications from either a person who is a chronic steroid user or is afflicted with a neuromuscular disease. Our intention is to provide you with the resources for proper care under critical circumstances during hospitalization. It is our hope that by following this protocol, it may result in an improvement to the patient's condition. We are confident that through viewing and sharing this protocol, a form of educating ourselves, our families, our friends, physicians, pharmacists, and many more in the medical society will take effect.
Hello, my name is Richard Schell. I'm a pulmonary specialist here at Nationwide Children's Hospital caring for patients living with neuromuscular disease. I'm glad that you have chosen to watch this video and hope that you come away today with the information necessary to care for patients with Duchenne Muscular Dystrophy. Emergency care of these patients is as complex as this disease process itself. Making decisions can be very difficult at times. Dr. Gary Noritz has specialized in the care of these patients with complex medical needs, and we'll be discussing today the important aspects of caring for patients with Duchenne in emergency situations.
Hi, I'm Gary Noritz. I'm an internist and a pediatrician at Nationwide Children's Hospital and The Ohio State University. I'm going to talk today about the emergent and acute management of patients living with Duchenne muscular dystrophy. In terms of disclosures, I have no financial interest to relate. I am going to be talking about the off-label use of Deflazacort, which is a corticosteroid that is not currently approved by the U.S. Food and Drug Administration. Our objectives for today, it will be one that the participants will be able to describe the major features of Duchenne muscular dystrophy, that you'll be able to evaluate a patient with Duchenne muscular dystrophy who presents with an acute illness, and that you'll be able to recognize and treat a patient with corticosteroid dependence and mitigate their corticosteroid dependence. I want to tell you a little bit about the case that brings us here today. This is PJ Nikoloff. He was a 31-year-old man living with Duchenne muscular dystrophy. He loved sports. He had a degree in web engineering. He played poker. And whatever he did all in, as his father said. He fell while on vacation in Florida and had a fracture and was transferred to a hospital where he underwent successful surgery for that fracture. Following the surgery, he developed low blood pressure, tachycardia, and trouble breathing, and he later died. In reviewing, it wasn't clear that he had gotten his appropriate dose of stress dose steroids. And this was one of the things that may have contributed to his death. So first, we're going to talk about Duchenne muscular dystrophy. What are the major features? So first of all, Duchenne and Becker muscular dystrophy are two sides of the same coin. One is the complete absence of the dystrophin gene. The other is the partial absence of the dystrophin gene. This is located on the X chromosome, so it predominantly affects boys, although women can be affected as well. Together, about 1 in 5,000 boys has either Duchenne or Becker muscular dystrophy in about a 2-to-1 ratio. This is a picture of skeletal muscle cells. On the left, you can see normal muscle where the muscle fibers are generally of about the same size and have a very benign appearance. In the second slide on the right, you can see muscle fibers of differing sizes with an inflammatory infiltrate and atrophy around the muscle fibers. On the bottom are muscle fibers that are stained for the dystrophin protein. On the left is normal, where there's plenty of dystrophin protein to be seen. In the middle is Becker, where there is missing quite a bit of the dystrophin protein. And Duchenne is the one on the right, where there's hardly any dystrophin protein to be seen. People with Duchenne muscular dystrophy have progressive muscle weakness, which generally begins proximally and spreads to the arms and the legs, which leads to loss of ambulation and skeletal complications such as scoliosis. There is progressive respiratory muscle weakness, which leads to hypoventilation and respiratory failure. There is also effect of the heart muscle, a primary cardiomyopathy, which is progressive and can lead to cardiac insufficiency and heart failure. In terms of disability and life expectancy, boys with Duchenne often become full-time wheelchair users by the age of 13 years. Scoliosis is pretty common, and the median life expectancy is age 19, but this is without the current treatments of corticosteroids. With steroids and assisted ventilation, ambulation is often preserved for several more years, their scoliosis is much less common, and the median life expectancy is into the 30s. As such, this is a disease that doctors who take care of adults, such as internists and family practitioners, need to know quite a bit about. These are the treatments for Duchenne muscular dystrophy that are currently in use. The biggest one right now is corticosteroids, and as these are drugs with many side effects, there needs to be monitoring for these side effects. Assisted ventilation is usually instituted late in the teenage years as the respiratory muscle weakness gets worse. There is the usual therapy for heart failure in terms of preload and afterload reduction. There may need to be a supplement of oral or enteral nutrition by feeding tube. There's a common side effect of constipation, and this needs to be treated as well. There may be orthopedic interventions if scoliosis develops, and if there are fragility fractures, bisphosphonates may be used. On the horizon, and hopefully very shortly, there will be disease-specific treatments for Duchenne muscular dystrophy, which corrects the genetic defect at the genetic level. Care for Duchenne is commonly provided in interdisciplinary teams, which often includes a neurologist, sometimes a doctor of physical medicine, a pulmonologist, a cardiologist, a social worker, a dietitian, a primary care doctor. There needs to be attention paid to the medical, but also the psychosocial and financial complications of living with this chronic illness. And then with increased life expectancy, transition to adult teams out of the pediatric realm has taken on increased urgency. I'm now going to discuss transition of children who have grown up with Duchenne to becoming adults with Duchenne. This is a Kaplan-Meier survival curve, which shows that over time, the life expectancy of boys with Duchenne has increased greatly, particularly with the addition of corticosteroids and assisted ventilation. Why is transition necessary? Well, for one thing, children's hospitals and pediatric providers may be unable or unwilling to care for adults with childhood-onset neuromuscular diseases. And at the same time, adult providers and facilities may not, or at least may not yet, have the necessary ability to care for adults with these childhood-onset neuromuscular diseases, such as Duchenne muscular dystrophy. And the patients and their families are often caught in the middle. One thing that's extremely important to remember when it comes to talking about transition is that transition is a process, it's not an event. And it shouldn't happen in the middle of the night. And one of the big problems we see is that the first time an adult with muscular dystrophy interacts with the adult healthcare system may be in a crisis without any preparation for that transition. And so this is a process that we believe really should begin early in adolescence and with increasing amount of responsibility for the young man as he grows up. I often think of transition as passing the baton, as runners may do in a relay race. And this is in fact a picture of the United States dropping the baton in the 2008 Olympics in Beijing. And why does this happen? Well, the baton gets dropped if there is not an adequate handoff between the two runners. And it's important, and I think it's a great analogy to say that the runner runs a lap, and then there's about 100 meters where the two runners run together. And they both hold the baton for that 100 meters. And the second one can't take off and run faster until the first one has let go of the baton. And at the same time, he can't let go of the baton until he's sure that the next runner has it. And really, this is the kind of thing we ought to be doing in healthcare, That transition is not, okay, go on over here to the next place. It's, let's work together to get you to the next place, and then I, the pediatric provider, can fade away a bit. A further challenge is that some adults with neuromuscular diseases may have cognitive disability, and cognitive disability is relatively common amongst boys and men with Duchenne. In addition, there's a physical dependence, even for those that have a typical cognitive development, which may impact their ability to grow as independent adults. It is a known fact that a substantial minority of patients with Duchenne muscular dystrophy have cognitive learning and psychiatric challenges. Patients are often reluctant to transition, and there's a few reasons for this. One is that the pediatric system has usually done a very good job of taking care of the patient. The patients feel comfortable, the families feel comfortable, the doctors feel comfortable, both in terms of the medical care that's provided as well as non-medical support. So the patients may not perceive that there is a need for transition. They may worry about the quality of care they'll get at an adult institution, and they may perceive abandonment by pediatric providers. And also, they may know that some of their friends have transitioned to adult providers and been dissatisfied with the care that they've received, and they may have died. I think it's important to realize that boys and men with Duchenne are extraordinarily well connected to each other through social media, through networking opportunities like the Muscular Dystrophy Camp. And so it can be a very tight-knit community, which means that the boys often know and the men often know what's laying in store for them down the road. And so they're aware that they have what's ultimately a fatal disease, and they are likely at varying degrees of acceptance of the fact that they have this disease. And they almost all have had friends who have died. And so they often worry, when is this going to happen for me? And they're at varying stages of acceptance of their situation. But transition's necessary. It may be required by the medical system, and some children's hospitals have rules that adults over a certain age cannot be seen there. The hospital or even the individual providers may set an age limit. And at some point it may no longer be safe nor practical to care for an adult in a pediatric setting. And another reason is that without transition, stability can become stagnation. And we want our boys and men with Duchenne to grow and to thrive, and not to live in a perpetual childhood. There are several common scenarios by which an adult with Duchenne may present for medical care in the acute setting. One would be dyspnea, palpitations, abdominal pain, back pain, or pain in a limb or swelling of a limb. We'll talk about some of the specifics of this. So the first important thing to remember is that something may happen to a person with Duchenne just as it may happen to a person without Duchenne, although certain things are more common in patients with Duchenne muscular dystrophy. Each of these scenarios needs to be evaluated in the context of the expected complications of the disease or the treatment that they're on. I want to stress that it's really important to trust the patient and their caregivers when taking the history. They know the backstory, they know the treatments the patient has received, they know what their pain tolerance level is, and they know how much trouble they're having breathing, for instance, even if it's not immediately seen when you examine them. The differential for dyspnea in somebody with Duchenne, just like other people, can be broken down into problems with ventilation, oxygenation, or worsening cardiac function. In terms of ventilation, there may be a decrement in muscle strength during an acute illness, such as a viral illness, or any ventilatory support that they're already taking, such as BiPAP, may be malfunctioning or functioning poorly, and so that needs to be evaluated. In terms of oxygenation, there could be problems in the parenchyma, such as pneumonia, pleural disease, VQ mismatch, as you might see with a pulmonary embolus, anemia, or even an upper respiratory infection can cause trouble breathing and difficulties with both oxygenation and ventilation. Simple viral illnesses can be very serious in patients with already corrupted ventilatory status. We often may see worsening of cardiac function, either from worsening of the cardiomyopathy, fluid overload, arrhythmia, not taking their cardiac medications as prescribed, and there may also be a significant anxiety component, which can cause shortness of breath. In terms of evaluation, the history is extremely important, as is the exam. Patients may have impending respiratory failure even though they look fairly well. Unlike other patients who are entering the late stages of respiratory insufficiency, they have difficulty recruiting accessory muscles, and so you may not see retractions or abdominal breathing, whereas the only thing you may see is tachypnea. Also, the weakness of the facial muscles may belie how serious the illness is because they can't make as great expressions with their face as you might expect. The imaging in laboratory is pretty standard for evaluating of dyspnea, such as a chest x-ray, a blood gas, and so on. The treatment really depends on the cause. I really want to stress that you should not use oxygen empirically. Patients with Duchenne should be assumed to have hypoventilation and thus rely on a hypoxic respiratory drive, much as patients with COPD do. And so to put oxygen on them without recognizing the degree of ventilatory dysfunction can impair their respirations further. Patients who are experienced users of BiPAP can often just put their BiPAP on, often at increased settings, and this may help them get over periods of dyspnea. If a patient with Duchenne should require intubation, certain things are important to remember. First of all, the depolarizing muscle relaxants such as succinylcholine should not be used due to the risk of rhabdomyolysis and hyperkalemia. Inhalational agents may be associated with malignant hyperthermia. And so it's generally recommended, if intubation is necessary, to use agents such as propofol, etomidate, vecuronium, or cisatracurium. It would be wise to prepare for a difficult intubation and to make sure there are experienced personnel available when intubation is planned, particularly if it's planned urgently. The airway itself may be smaller than you're used to for adults of the same age, and the opening of the jaw may be limited by contracture, and so it may be difficult to adequately visualize the vocal cords. Sometimes fiber optics would be necessary. In terms of dyspnea treatment, opioids in low doses and carefully monitored can be used safely. Mucus clearance is of paramount importance, and in terms of moving the mucus from either an upper respiratory infection or pneumonia, may be even more important than the antibiotics for getting somebody through a respiratory illness. For those patients who require intubation but are experienced BiPAP users, BiPAP can be used as a bridge to extubation, as they are already used to using this technology. In terms of heart failure, you have to have a high degree of suspicion for this because the history may be kind of vague and nonspecific. The patients may complain of fatigue, weight loss, or vomiting, and not really dyspnea, but that may happen as well. The exam can be quite difficult, and so it's important to try to get a weight, but that can often be difficult to do even in a patient in a wheelchair. EKG and rhythm monitoring is important. Labs such as a B natriuretic peptide can be helpful in sorting out whether a person's in heart failure or not, and imaging with echo would generally be preferred in the acute setting, even though cardiac MRIs are often used chronically to monitor the heart function of these patients. The treatment is fairly standard, as with other causes of heart failure. Diuresis is used to reduce preload. Afterload can be reduced with ACE inhibitors, nitrates, or other vasodilators, and if there's dysrhythmia, that should be treated as well. Often these patients, in conjunction with the cardiologist, might receive resynchronization therapy, left ventricular assist device, or even transplant. For adults with Duchenne who present with abdominal pain, there can be a myriad of causes, both serious causes and not so serious causes. Common things that we might see would be reflux, gastritis or peptic ulcer disease, constipation, but also surgical diseases such as ileus or volvulus, kidney stones, and heart failure can also present as abdominal pain. The workup and treatment for this, again, depends on the cause and is fairly standard. Many of the adults with Duchenne complain of back pain. One reason might be kidney stones. Another could be a compression fracture of the vertebrae, which is often seen even without the use of steroid treatments, but much more so for men that use steroids. Discomfort just from the way they're seated in their chair can often be the cause of this discomfort. The standard treatments for these apply as well. Should a person with Duchenne come in with a swollen or painful leg, it's important to think about fracture, as this is more common in any patient that does not use, that is not ambulatory, but also in those patients with high-dose steroids. Blood clots are possibly more common in patients with Duchenne and Becker muscular dystrophy. The workup for these, again, would be X-ray, Doppler ultrasound, and anticoagulation should be very important for somebody found with a DVT, but also for anybody who's had a fracture. I'm going to talk now about recognizing and treating patients with corticosteroid dependence. Specifically, we're talking about boys and men with Duchenne muscular dystrophy, but this goes for any patient that takes steroids chronically. And this is what has become known as the P.J. Nickoloff protocol. I'll just remind you that the hypothalamic pituitary axis controls a secretion of cortisol from the adrenal glands, and that this is disrupted when exogenous steroids are given. In terms of the corticosteroids that are innately secreted in our body, in terms of a basal secretion, we usually make about 8 or 10 milligrams of hydrocortisone a day. During a mild illness, the adrenal will recognize this and produce up to 50 milligrams of cortisone for a single day. And during a severe illness, this may be more on the lines of the equivalent of 75 or 150 milligrams of hydrocortisone for 5 days. When patients are taking steroids chronically, the adrenal gland does not recognize the acute illness and will not make these steroids in response to stress. How much prednisone does it take to suppress the adrenal axis? So if somebody's taking 5 milligrams or so of prednisone a day, they're usually not very suppressed. Anything that or less is okay. Between 5 and 20 milligrams a day of prednisone, they might be suppressed, and an ACTH stimulation test is recommended, or to just give a supplemental dose if there's any suspicion for adrenal insufficiency. And anybody who's taking more than 20 milligrams a day of prednisone for more than 10 days should be assumed to be suppressed, and supplemental doses or stress doses of corticosteroids should be given. Many patients with Duchenne take Deflazacort, which is a corticosteroid that's not available in the United States but can be brought here from Canada and Europe. This is a derivative of prednisolone with similar anti-inflammatory and muscle-preserving effects, but is thought to have much less side effects. There's better preservation of bone mass, less weight gain, better lipid profiles, less glucose intolerance, and less scoliosis. This may be at the extent of more cataracts. And just as ballpark, about 6 milligrams of Deflazacort is equal to about 5 milligrams of prednisone. You can find online different ways of dosing corticosteroids equivalently, so that if somebody is taking a different course of steroids or if somebody is on IV steroids, you can figure out what their amount of prednisone equivalence is. What are the risk factors for an adrenal crisis? So one would be dehydration, an infection or other physical stress such as a trauma or a surgery, an injury to the adrenal glands or pituitary glands themselves, or if for some reason somebody stops taking their exogenous steroids. And in PJ's case, not only did he have a trauma and then a surgery, but he was in the hospital and not given his exogenous steroids. And so an adrenal crisis was precipitated. There are many symptoms of adrenal crisis, and so you need to be alert to any or all of these. In blue, I've highlighted the ones that we see most often: abdominal pain, confusion, dehydration, fatigue, flank pain, fever, loss of appetite, low blood pressure, nausea, rapid heart rate, or rapid respiratory rate. You can also find in many online resources stress dosing of steroids, and this is in the P.J. Nikolov protocol, which we will have the link. For a minor surgery, such as inguinal hernia repair, extraction of a single tooth, or a mild febrile illness, the corticosteroid can be increased briefly, and no taper is necessary. For moderate stresses, such as multiple teeth being extracted, a fracture, or pneumonia, a larger steroid dose should be used, and this should be tapered, but this may be tapered quickly. For major stress, such as septic shock, multiple trauma, severe burns, pancreatitis, spinal fusion surgery, large doses of steroids are needed to support the patient who has adrenal suppression, and those steroids need to be tapered over time. In conclusion, I'd like you to know that the majority of children with Duchenne muscular dystrophy will live through their childhood into adulthood and will end up seeking care from non-pediatric providers. These patients may present to internists and family doctors with critical illness, and those doctors must be prepared to evaluate and treat them. And most importantly, patients on chronic corticosteroids should be assumed to be steroid deficient and to need replacement stress dosing in the event of severe acute illness. Thank you.